What I really want to do today is explore the culture issue. We have a brilliant service, the NHS, and a lot of good happens every single day. And one of the things that I'm really, really conscious of is that there are challenges around the culture which for many years were very much swept under the rug. And I'm going to be sharing some stuff with you today that's quite tough, that's really quite challenging. But actually, I am really buoyed by the fact that we are discussing it now, because that is the first step to change. And I can see a load of initiatives underway that will help make our NHS a more diverse, a more inclusive, a more compassionate place to be. So that's the plan. And I was looking at some of the chat during Abby's session, and I know that there were a couple of questions around that. So I hope that whatever role you're seeking to go into, as George was saying, this is useful for all of you, not just our doctors and those seeking to join that path. So my aim, as I say, is to really lay out that case for change and then explore our professional standards. And yes, I'll be talking about the professional standards we produce, which is for doctors, anaesthesia associates and physician associates, but they are very broadcast and link very much to anyone working in healthcare. I'd also really like to explore your ideas around this, because you are the future of the NHS. So I think your ideas around implementing this is really, really valuable. And it's a bit of a call to action really as well for anyone else on the call who is in the system now and can help drive forward what we need to drive forward. So before I start with the detail, all of that, as George said, I'll introduce myself a little bit further. George mentioned that I've been in and around healthcare for quite a while now. It's getting on for 25 years. I work in the SARCs. Those are the Sexual Assault Referral Centres, where I work with survivors of abuse. I don't do as much as I'd like to these days because my main job now is at the GMC. So I tend to provide support on a voluntary basis with the organisations I'm linked with the domestic abuse services and the sexual violence services. So I do that on an ad hoc basis, but work very closely with the partners. And it was that work when I was full-time that got me really interested in how, when as a system, we don't work well together, and when we don't support our professionals, our clients, as we call them in those services, or patients more broadly, they're the ones who fall through the gaps. So that got me interested in supporting professionals and, as I say, systems working, how we get better at all of that. And at previous healthcare conference events, I've spoken about that system working. So when the GMC back in 2010-ish asked me and a colleague to set up a support service for doctors on the ground, I was really enthused by that opportunity. It's not something that I'd ever seen a regulator do, and that idea, that approach has now spread, which is really, really good to see. So being asked to do that, I jumped at the chance, and I remember at one of my very, very first conferences where I was just at that fact-finding stage to learn about what partners needed in the system, what would be most useful for doctors on the ground. At that point, we were trying to learn more. So at that point, at one of those first conferences, I was introduced onto the conference podium to the theme of the Imperial March. And that's Darth Vader's theme tune, for those that don't know. And that moment really crystallized for me just what fear we're beheld in. And I understand why we are thought of predominantly in fitness to practice terms, because ultimately it's not just a job, is it? It's about livelihoods as well. But as I learned more about what we do at the GMC, and this next slide here shows you all our statutory functions. And as I learned more about that, it became really, really clear to me that standards there in the centre, that's the absolute fulcrum of what we do. And I would argue in many ways that it's more important for patient safety than fitness of practice there at the bottom, because the really, really serious fitness to practice stuff applies to such a tiny minority. In fact, and sorry, the animations aren't quite working, but under that standards note there, it says 0.0025%, and that is the percentage of doctors each year where we see those really, really serious issues. So as I say, a tiny minority of colleagues. And that means that logically, but most importantly, morally, the more that we can do to support colleagues to deliver what are challenging standards in an increasingly challenging environment, and I was saying that pre-pandemic as well, well, that is where we need to be. And that's where we are. So as George says, said, I co-lead the outreach team, and I'll just let you read the bullets there, which cover a brief précis of what we do. Okay, so wherever you are based, you have direct points of contact at GMC Outreach, and we all live and work in our regions and nations. So, we have an understanding of the local picture as well as obviously the broader picture nationally. And it says there that we're an upstream supportive intervention. I'll come back to that. The second bullet around that consultancy to hospitals, medical leadership groups. So we're made up of a number of specialties. So we have people with clinical backgrounds, we have people with medico-legal backgrounds, we have people with educator backgrounds and more. And when we meet with those medical leadership groups, what we're exploring there is what support is needed. So let's say we hear about challenging cultures in one of the departments. So a program that we are currently running and have been for a while is around obs and gynae, because we've heard about, I'm sure you all have as well, about the challenges in maternity. So we'll explore with the leadership group, okay, what support is needed to help improve the culture here to ensure the best for our colleagues and patients. We'll also explore early interventions to prevent fitness to practice thresholds being reached. So that side of it is another conversation that we have with employers, if you will. Then going to the third bullet, that's where we provide the supportive educational interventions. So around culture, as that example that I gave around maternity, one of the programs that we have is called Professional Behaviours and Patient Safety, where we look at the infrastructure of the organisation and then look at workshops for the relevant department to really, really explore the interactions between colleagues to ensure that those lower level professionalism behaviours aren't allowed to escalate, that they are actually nipped in the bud to create that more welcoming, convivial, appropriate environment for work. So that's one element of what we do, but we may also, and frequently do, teach on our other standards as well. So for example, we will run workshops on end-of-life care, on confidentiality and sexual health, on decision-making and consent. So anything that we have professional standards on, or anything more broadly, GMC, we will run those workshops. And that brings me to the final bullet. And I think this is a really important one, because when we are there out on the ground, we of course hear what's happening. So I don't unfortunately get to teach that much anymore. But going back to one of my very first workshops when I used to very regularly, it was a group of Foundation Year 1 doctors. And we were talking about raising concerns and leadership more broadly. And one of them said to me, well, last weekend I was with 47 outliers on T&O in trauma and orthopedics, and they were on their own. And they explained, and in fact the team explained, that this had been a challenge in that department, that out of hours support and cover had been a challenge in that department for a long while. And whilst they had been raising it, nothing really changed, not in a longitudinal way anyway. So when we hear about things like that, then we can intervene. So we're able to pull the right levers, have the right conversations, support our groups of doctors raising these issues at that very local level, but then also more broadly. So going back to 2014, there was a pretty seismic case around, it was around decision making and consent. And I won't go into all of the details of that because that would take up an entire day. But it really worried the profession, because it changed, that there was a change in the law essentially. And that judgment, as I say, caused a lot of worry. And my team were picking up on the ground that that colleagues were worried. They didn't know what they should be doing now with this judgment from the courts. And that meant we were able to inform policy at national level to help shore up confidence, to create that clarification that was needed as well. So that's an overview of what we do at GMC Outreach, and it is essentially upstream regulation. Now, there's a load of academic theory behind this, so again, I won't go into the detail, but if I was to boil it down to just, I guess, one sentence, upstream regulation, and it actually comes from the utilities sector. So wherever you are regulating, whether it's utilities, whether it is healthcare, if all you are doing is striking off healthcare professionals or fining utility companies, as a regulator, you have therefore failed, because the public, as well as colleagues, have come to harm. It's too late. So the idea of upstream regulation is that you expend your energy well before that point to prevent harm. So it's essentially harm prevention. And that has been our philosophy for a while now at the GMC. Now, of course, we work in a continuum. And this brings me to the purpose of the talk. So that reforming of regulation to embed equality and compassion. Okay. As I say, we work in this professionalism continuum. And if you look at the standards and guidance side of that continuum, the respect, the civility, promoting professionalism, that's what I was talking about in terms of where the investment needs to be, our investment of our energies as well as, funding. Because, as I say, once something goes along that continuum, so once, if you think of the employer, once something goes into human resources, HR processes, then again, it's too late. People have been disrespected, there has been incivility, there has been harm. And in some of those cases, there will be a fitness to practice referral to the GMC, the NMC, the HCPC, etc. And again, it's too late. Yes, of course, you must, as a regulator, then deal with it. But were there those opportunities much earlier to prevent that escalation? So what we want to do with our partners and the conversations that we've been having for a long time now, the actions that we've been taking have been around working with them to embed standards that make a difference. We've produced a number of reports and initiatives, and I'll come to those a bit later. So a couple of the most seminal ones were from 2019. There were also activities before, but I think the two reports from 2019 were particularly impactful from my point of view. But there is another change coming in terms of the standards as well themselves. And the reason why I think that that is particularly important is because standards tend to stand the test of time. So whether we are looking at the Imhotep papyrus from Egypt from millennia ago, whether we're looking at the Hippocratic Oath, those standards, many of them are still what we work to today. And I've translated a little bit of the Hippocratic Oath there. So I'll just let you read that. And that quote there, essentially, that's confidentiality, isn't it? It's in a nice archaic language, as one would expect, but it is talking about confidentiality, which is absolutely a core tenet today. Now, I'm just going to show you the next slide. And there's a guy called Paracelsus back in the 16th century. And please try and focus, first of all, on the where it starts with a clear conscience rather than the other half. I'll have to get the animations working next time because it's quite a stunning reveal. So if you look at the left side, that side shows you standards which seem pretty normal today. And the only thing that isn't normal, well, perhaps it is normal but isn't right, is the sexism, but I won't excuse it, but I'll tolerate it because we're talking 16th century. What he went on to say, the 4 bullets on the other side, not particularly what we would think of today, ranging from the sublime to the ridiculous to, well, eyebrow raising for a variety of reasons. And I guess that's another really important element of standards, because standards happily evolve with what we call the social contract. So as society's needs change, as the conversations in society change, the standards need to evolve too. And that brings me to the next slide, and there's a little video, a GIF there that's not quite playing, but the question, it remains salient. So good medical practice, those are the core professional standards that we produce. So going back to the jigsaw slide right at the center, good medical practice was last reviewed back in 2012 and launched in 2013, so 10 years ago. So over these 10 years, we were asking ourselves, what's changed now? What are the biggest challenges now through a modern lens that we need to update in the new good medical practice? Okay, so we had a big consultation last year exploring the issues, and the new standards will be launched very soon, looking at these questions and providing, as I say, new professional standards around these issues. And one of the biggest issues, of course, is systemic discrimination. As I said, some of the information I'm sharing with you today is going to be tough, and I'm going to start with these data And I'll pause and just let you digest those data for a moment. Okay, so over the last few years, we have seen that significant rise in international colleagues joining the NHS versus far fewer UK graduates. And I'm talking about medicine here specifically. So it's from, these are GMC data. Okay. Now, the second bullet talks about how by 2030, if current trends continue, then LE, that's locally employed doctors, and SAS doctors, they will be the majority. Okay. So, sorry, that's a specialty and a specialist grade doctors. So they will be the majority. Now, 70% as it stands of locally employed doctors, so that means that there is no national contract, whereas doctors in training, consultants, GPs are on national contracts there. SAS doctors have national contracts too, but locally employed doctors, they are employed locally by the organisation. There is no national contract, so you can imagine that there are quite varying terms and conditions there. And both those groups, very different, but they are traditionally the groups that receive the least support. Okay, and 70%, as I say, of our locally employed doctors are IMG's international medical graduates. So that is worrying, that our international colleagues are going into roles that are often less supported. And then this is where it gets really stark. Minority ethnic doctors are twice as likely to be referred to as. Okay, and that's minority ethnic doctors more broadly, not solely international medical graduates, but qualify in the UK, minority ethnic, more likely to be referred. And these trends, I know NMC have data around this as well, so we know there is also disproportionality there. And then coming to our IMGs, our international medical graduates, they are 2.5 times as likely to be referred by their employers. And of course, that means that there is a real issue with workforce morale and retention, and it has to stop now. Our international colleagues, well, all our colleagues, but our colleagues bring their skills, their dedication, their compassion to the NHS, to the patients every single day. So where is that recognition? Where is that support to make a change around all of this? And there's plenty of research around diverse colleagues' experience as well. And these are the two reports that I mentioned from 2019. And I've just picked out a few themes from these. Clearly, they're both weighty tomes, but I really would recommend that you scan at least the exec summaries. They're available on our website at open access. But looking at these bullets, we can see that these independent reports found that some doctors are treated as outsiders. And there's a lack, and it can be a relatively complex picture. It is not down solely to, so we were looking at ethnicity. So staying with the focus on ethnicity for a moment, it is not solely down to individuals being racist. And that's what I talked about, systemic discrimination. So looking at the factors, that lack of timely supportive feedback is an issue that we see time and time again. So because of these inside-outside groups, those outside groups don't necessarily have that coffee cup type of conversation. As a friend of mine says, he's internationally qualified, joined here decades ago, and then it was the norm when you had a good relationship for someone to say, let's go for a beer tonight. That's just something I want to chat about, and then have that chat, feedback essentially over a beer. Now, beer is not necessarily the most inclusive option, but it could be a coffee, it could be a tea, it could be anything. The point is that kind of feedback is not happening with certain groups. And we all know what we mean by certain groups. And these reports go into the detail. Then there is inadequate induction. And I'll come back to that a bit later. And in terms of cultures more broadly, those working patterns and leadership challenges that we've been hearing about, well, since Ely, but you may be more familiar with mid-staffs. So there is a lot of work to be done there. And another element, the second report, Caring for Doctors, Caring for Patients, talks about the ABCs of doctors' core needs. And this will apply to all healthcare professionals. We need that sense of autonomy, a control over our working lives. We need to feel like we belong. Now, I was very lucky that the kind of service that I'm in, that sense of belonging, that camaraderie is really very apparent. And if it wasn't there, given the patient cohort we're supporting, I can't begin to imagine how difficult that would be. Yeah. And we need to feel competent, as in, we might have our clinical competence down pat, but if our environment doesn't allow us to be competent because of workload, lack of resources more broadly, well, then we're going to feel that moral injury, essentially. Okay. So, with all that in mind, going back to how we embed that equality and compassion, I'm going to talk about collaboration. So, some of you may be interested in a report that we've just published. Now, the previous reports on the earlier slide, they were research projects, but this report on equality, diversity and inclusion talks about actual progress and actions. So sometimes organisations, including the GMC, get criticised for just producing reports, and people understandably say, okay, there's the talk, but where's the walk? And there are also plenty of actions underway, and this really takes you through them. And one of those actions, just going back to that disproportionate referral that I was talking about earlier, one of those actions is that we set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education. It's quite an interesting one, because if you think of, you may have heard of John Covey's circles of control and influence, and I'll share that with you a bit later on as well. But we all have things that are within our circle of control. So we've got direct power, direct control to make changes. Then we've got things that are merely in our circle of influence, okay? So we don't own it, as it were. We can only influence. And then we've got things that are in our circle of concern. We have no influence. We certainly don't have control. So we're just concerned about those, and we need to escalate. So if we think about those disproportionate referrals, it's an interesting one to set ourselves a target to eradicate that disproportionality, because the referrals come in from employers. And if you think about the leadership team, going back to the slide that had arrows on, the continuum slide, if you think of that, actually by the time that something gets to the sort of top tier leadership team that might make those referrals, well, a lot has happened before that. So they are possibly not getting the full picture either, going back to upstream and the need for it. So but speaking of the target, it is a really challenging one because we don't control it. But we think it's important to set the target because it holds us and our partners to account to really push on that upstream influencing agenda to get those early interventions in place. And the report takes you through some of the examples of work being done in that space, where we're working, for example, with NHS Resolution, who work closely with employers to train leaders lower down, if you will, closer to the ground, to ensure that they are embedding proper equality, diversity and inclusion practices at that level to try and prevent escalation. So there are a number of initiatives underway, and we've seen success and a change with some of those. And one example of the good news, clearly a long way to go still, but one example of that is, if I was giving this presentation last year, then I would have talked about how our international colleagues were 3 times as likely to be referred to the GMC. Okay. If you remember from earlier, I said 2.5 times. So we are seeing a change. So it will happen. Perhaps some might say that I'm naive, but I've seen a real step change in the last few years where people are moving from the talk to the walk. And that brings me to the image on this slide. And I'm going to be talking about this a bit later today in the second session that I'm doing. And that is welcoming and valuing our international medical graduates. So this is an induction program. We've been calling for induction, supportive induction for international graduates for a long time. And there was interest in the system, there was appetite, but there was limited. Again, going back to the circles of control, actually, I'm going to take it down that route. That all those organisations that we were speaking with, the employers, there was limited control and ownership around who could deliver it. And it's not within our regulatory, if you will, remit. We don't have the statutory power to make it happen. So we only have this in our circle of influence. Happily, last year, and actually with the help of colleagues here at Health Careers Conferences, we were able to, in collaboration with a number of partners, and that includes the Medical Workforce Rate Equality Standard at NHS England, the BMA, the MPS, a number of organisations, we launched this comprehensive induction. So that now exists. So I'm sharing things that are really challenging, but I'm hopefully also sharing progress, because there really is progress. Now, some of you may be aware about the reforms to our own processes as well. So I just want to touch on that briefly, because we do need root and branch reform. Now, there are far too many cases. Yes, we've talked about that disproportionality coming in through to us, and that there are many cases that we don't want them. We can't see a purpose in terms of supporting colleagues, protecting the public, all of that, to taking these cases forward. But the law, as it is written, it's the Medical Act from 1983, requires us to take these forward, to escalate these to tribunal, etc. And the way that it's set out, it's a really adversarial process. The only process that is less adversarial, well, not adversarial at all, actually, is the health process, where the aim is to really, really support those colleagues until they are better. But anything else that doesn't come under health, it can fall into a really adversarial process. And we need that to change. And we've been lobbying for a change to the law, well, since 2013, actually. That change is now happening. the department drafting legislation around that. Well, drafted legislation, it's going back and forth at the moment. So that change will come. But to be clear, until it does, there are many things that we are stuck on. We need to continue following the law, which calls for pretty adversarial process that we don't like at all. Now, as a result of that, I don't want to just say it's all someone else's fault. I'm not abrogating us of all responsibility here. So there are things that we can do. So for example, if someone finds themselves in that situation, we commissioned the BMA, whether you are a member or not, to provide doctor support services, free peer support service for anyone that is referred. And there are a number of other initiatives like that to provide as much support and psychological safety as possible. But the main thing is that law needs to change. We need that regulatory reform to become far more compassionate, well, to provide that far more compassionate approach to the fitness to practice element. Until we get that change, we'll continue to do the things that we can, looking at those reports that I highlighted to you and the actions and influencing activities we undertake with our partners. And that brings me back to the standards. Okay. So how can good medical practice help? We said earlier that standards tend to stand the test of time, and as the social contract evolves, we adapt our standards to help drive forward that cultural change. We've seen some of the data. It's really hard hitting. That data focused on ethnicity and the discrimination there, the racism there. I want to now look at some lived experience, and this is probably the toughest bit that I'm going to be sharing with you today. And this lived experience looks at discriminatory comments across the sphere, if you will. So these are all comments that my colleagues have heard on the ground. A couple of them are my own examples, actually, that I've been subject to, but the rest, things that colleagues on the ground have been subject to. I'll let you read those. Okay. So blatant sexism in the first one. The second one, again, misogyny. Now, this was a medical student who was doing their OSCE, their practical, and their supervisor. So think of that power imbalance, yellow carded them, which is such an archaic system anyway, actually. That's not the culture we want, yellow carding and red carding. And the dress, by the way, was mid-calf length. It's beyond diabolical. The third example, a colleague in Newcastle who hadn't had curry, but I think a lot of us from Asian backgrounds will experience this. I certainly have. That one, it's because of all the Asians overheard in an NHS staff room at the first pandemic peak. The staff promo picture one, that was in a marketing communications team. So it's really concerning that someone had the confidence to say that. What's interesting and positive is that it was raised, as in it was escalated as an issue. Okay. I'm not going to talk about the penultimate one, because I will get incandescent beyond saying that it's absolutely vile, like all of these. And then the final one, to an autistic colleague. So these are some of the types of negative experience diverse colleagues are subject to on the ground every day. And going back, thinking back to the 90s, This happened. This isn't new, but people didn't talk about it. So whilst I am sharing, as I said, this tough stuff with you, I want to be really, really clear that I think this is positive in the sense that we are now talking about it, stating very, very clearly that it won't be tolerated, that there is action to change it. Because were I talking to you back when I started my career about these issues, well, there'd be shock because we didn't talk about things like this. And we all know that civility saves lives, literally. I use the word literally with impunity. And these are some stats from Civility Saves Lives, whom we work with. And I'll let you read those. And again, back in the 90s, back in the 2000s, back in the 2010s, etc. Clearly, these statistics will have been the same. But nobody knew, nobody talked about it. It was all, let's be stoic and just get on with it. But with organisations like Civility Saves Lives and many others, this is now held up rightly as a red flag that it is. It impacts hugely on the recipient, also on those witnessing, including the patient and those close to them. So there is we talk about evidence-based medicine. I remember when evidence-based medicine came in, and there was talk at the time that there were two things being developed. One was EBM, evidence-based medicine. Another was VBM, values-based medicine. EBM, evidence-based medicine, took off. Values-based medicine didn't take off as a concept, as a thing that we really embed. But where we are now, we have a really academically strong evidence base around the need for the values base to be driven. And these are just some of those data that build that evidence base. And collaboration, it's a way forward to embed that compassion, to eradicate the inequity that we see. And those new standards that I talked about, the new good medical practice, those new standards, whilst of course they've always talked about treating colleagues, treating patients with respect, being explicit about discrimination will help. You need that at the start of the continuum, don't you? Being really, really clear and anti-discrimination as opposed to individuals not being sexist, not being racist, etc. These need to be the professional standards. So we think that they will be a lever for change. But of course, you can't just produce standards policy on anything really and just stick it out there and expect it all to happen magically overnight. The key thing when producing standards is to look at the implementation. And this is where, as I've said before, that collaboration piece is really, really important. So the international graduate induction that I was talking about earlier, we'd been saying for ages that was needed. We'd been, talking to press about that, talking with our partners about that, but it was the collaboration that made it happen. So it's that collaboration that will make the changes still needed in the system's journey, society's journey around equality, diversity, and inclusion. Okay. So with that in mind, I just want to give you an overview of some of the resources that we've developed and are developing in this space. So I'm currently working on a suite of videos to really provide that immersive, experiential take on some of these issues that we see. So this particular story that I wrote, you'll see there a doctor walking along with a nurse, another doctor leaning there on the table. So as the doctor is walking down the corridor, her colleague, the doctor is called Dr. Banerjee, and her colleague says to her, right, patient bed 6 or whatever, see you later, Dr. Ban. Remember, her name was Dr. Banerjee. Okay. And then her doctor colleague sort of raises an eyebrow and says to her, Dr. Ban? And she says, yeah, they can't say my name. I mean, Banerjee. So that's the first thing that happens to her. Then she goes in to see the patient. And the patient immediately seems that she's not a doctor. Many of us women will experience that kind of thing. And then gets overtly racist as well by asking her, not only just asking her where she's from, she replies in her broad Geordie accent that she's from Newcastle. Then she gets the, where are you really from? And he doesn't want to be treated by her. Okay. And then we have a reflection to camera piece from the doctor where she talks about her experiences, the kinds of things that she's had, where she lets the sort of microaggressions go because the people aren't being unfriendly, because these big things, when patients are being racist, are so tough to handle. And what we want to do with this is turn this into a workshop. We have these discussions anyway, but I think that, as I say, that immersive experience to really envisage the way that Dr. Banerjee feels, how she's made to feel, will make a difference. So we not only want to explore those thoughts, those feelings, what colleagues should be doing when standing by, but also look at what leaders should be doing to get this out there, to help colleagues understand what is needed to help ensure that our Dr. Banerjees of the world aren't subject to those experiences. And when you have overt racism, for example, from a patient, that the organisation needs to act, that Dr. Banerjee needs that psychological safety to know that she has that belonging, going back to the ABCs, having that belonging in the environment she works. Then another example, I mean, I'm making a suite, so I'm only covering a couple of the examples here. Some of you may have heard the increasing stories around sexual harassment in the workplace. Now, given the field that I worked in, I can tell you very, very clearly that this is unfortunately not new. The stories that I'm reading and seeing, the work that is being done by the likes of Surviving in Scrubs, the Working Party, and sexual misconduct in surgery, etc., that work, those stories, they are not at all a surprise. They are still a shock every time, but they're not a surprise. So in this scenario, here's Dr. Lee, and she's in the mess room, and then a consultant pops his head around the door and says, where's our hottest new trainee? And her colleagues look really uncomfortable. No one says anything. She visibly withdraws and kind of pulls the cardigan around herself. And then it goes to a cut scene where she's talking about her experiences dealing with this consultant, how when she's raised it, she's been told, yeah, but he's a really good doctor. And in this cut scene, she's flashing back to a moment where he essentially corners her to offer help with her audit. She gets away, he doesn't try anything further, but it's a really claustrophobic scene. And I want people to watch that, feel that claustrophobia that Dr. Lee is feeling, and be galvanized to act. So that's another resource. And as I say, I'd really welcome any ideas on anything else that we should be exploring with our partners when we're delivering this. And that brings me to cascading and embedding. Okay. So there's loads now in place in terms of resources. The ones that are already in existence, the ones that are being developed will be ready imminently. And these resources include that induction that I talked about, improving supervisor competency as well, around ED&I, around equality, diversity and inclusion, those early intervention programs, and then loads of resources on our website as well, online hubs on racism, on sexual misconduct, on the broader resources such as decision making and consent, end of life care, etc. And a load of a myriad collaborative projects underway. So I think for those of you in the system that can help make a change now, knowing about it and cascading and working with the outreach team, my team, to help deliver some of this, please do. So that's sort of my call to action. And those of you coming into the system, to be really, really clear, as I said right at the start, good things happen every day. I hear about good experiences every day, but that mustn't mean that we don't talk about the things that need changing. And knowing that and knowing what's available empowers you, I hope. So yes, that's what I'm hoping to do, empower you with these resources. And for those interested in the how, for those wanting to drive forward this work, there are loads again of resources on the how, and my team can do some of that with you as well. But for example, the King's Fund report, this report, after Black Lives Matters, there were loads of reports looking at what could be done. And there's a pretty good evidence base that things like training on unconscious bias, I don't even like that term for a variety of reasons, doesn't really make a difference. And in fact, can in some circumstances set us back further. However, there are lots of positive findings around what we can do. So unconscious bias training, perhaps not something we should do, but allyship training, is something that does make a difference. So there are resources that talk about activities that actually make that difference. And when we're doing any of this work, self-care and how we influence, both of those things are really important because it's hard work to do. So as we wrap up, I'm just going to take you through some ideas around self-care and some tips around influencing. So again, if you can try and imagine this in the way that it's intended as an animation. So it starts off in the bottom right quadrant as you're facing the screen. And the question is, what are your core values at work? And I did this for myself. So the bullets are my own answers that I'm sharing with you. But ideally, if you just take a moment to think, what are the core values that you want to bring with you each day at work? Okay. And for me, because of the work that I do on medical ethics as well, these were mine. And then the next question is, what are you thinking and feeling when the context, that environment, doesn't allow you to deliver on your core values? And for me, I'm thinking and feeling that I'm stressed, I'm negative, I'm tired, I feel a lot more isolated, I'm certainly disengaged. So that's what I'm thinking and feeling when I don't have the environment that I need. What am I doing when I don't have that environment that I need? Well, I'm withdrawing a lot more. I'm deprioritizing different areas where I know I could drive change, where I could make a difference. Interestingly, I take a lot more home with me. when I don't have the environment that I need, when I feel like I'm on that hamster wheel. I take a lot more home with me. But when I am working in line with my values, when my environment is supporting me, I become a lot more creative. I get involved with things that will drive that change. I'm actively building that inclusive environment, and I'm listening a lot more rather than merely doing. And I think this exercise is a really good sort of barometer check for your own well-being, because when we can't live our values, whatever they may be, that is the first sort of warning sign that we're going to need help. And that help could be, taking a break, could be just a, brief holiday, or it could be something much more substantial than that. It could be a conversation with the team around how we're working together. It could be a conversation with leadership that there is a problem. It can be a range of things, but you might, whenever you find that you can't live your values, you need some form of intervention, whether it's small or big, depending on how grave the situation is. So my tip to you is have a list. It could be physical, mine's on my phone. Have a list of the values that you want to demonstrate at work every day, and use that as a sense check. So I use it at appraisal whenever I'm reflecting in one-to-ones or things like that. And that is, as I say, that's my early warning sign that I might need a bit of a break or something more serious. And if it is something more serious, remember, there are all of those resources available, whether it's freedom to speak up in NHS trusts, whether it's outreach. And then when it comes to extending your influence, we talked earlier about John Covey's circles. So yes, there are a number of ways you can do that. And we run full day workshops on this, and just sharing some of the sort of resources from that, because clearly I'm not going to do the full day workshop now, but I use Cialdini's 6 Principles of Influence, and it works. It makes such a difference. So if you look at the first one, reciprocity, that is, if you help someone out, they're likely to help you out. So that relationship, really. The second one, the commitment and consistency. So putting that in a healthcare setting, let's say that you want to make a difference around improving diversity, and a leader at the organisation has said that this is really important to them. Well, no one wants to seem inconsistent. So if you go to them and say that you've had a really good idea about widening participation or whatever it might be, and that leader is someone who's already provided their commitment, they're going to want to seem consistent, and they're a good person to help support that. And that could be anything. I've talked about diversity, but it could be, quality improvement projects around handover or whatever. Social proofing. This is a really interesting one, and it works incredibly well. Some of this work, as I say, it's hard, not just for individuals, but for the organisation, because the organisation has so many priorities. But if you can say to an organisation, well, Leicester down the road have just introduced this thing where they focus a lot more on positive always events, or they've just implemented a load of learning on having conversations around sexual harassment that's making a real difference. There's your social proofing. Leicester's doing it, so we can do it. And we use that for the International Medical Graduates induction, actually. Trust down the road's doing it, so we should do it. And then there are other things as well, like liking. So those who see themselves as part of your group are more likely to join with you. So, if you're speaking with nurse colleagues or paramedic colleagues, you might say, you might need another paramedic to roll out that idea, or a nurse colleague to roll out that idea. Authority makes a difference as well. And scarcity, this is an interesting one. Sometimes when people are asking for help, they will say, I really need help with this thing. Reframing can really help. So instead, what you might say is, there's this really, really good initiative. There's only a couple of people, a couple of places left to help drive it forward. Who's interested? And that's a very different proposition from, please help me with this thing. And, you know, in healthcare, we spend a lot of time thinking about and preparing for things like breaking bad news, rightly so. How much learning do we do, and how much preparation do we do for influencing? Because it's just as important, because it drives change for us as well as our patients, in the same way that we need to be compassionate when we're breaking bad news. So some things to think about there as well. And as I wrap up, I just want to flag again that all of this does make a difference. This induction is proof in the pudding of that. This induction, without it, it speaks to embedding compassionate healthcare. It is crucial to equality, diversity, and inclusion. It happened because people care about this finally now, and there are those that we can influence in the system to collaborate to make things happen. So I've shared some difficult stories with you today, but I hope I have also shared with you examples that demonstrate that we're in a place now to drive all of this forward. So yes, I hope that you are all galvanized and can see how our standards and all of these collaborative initiatives to embed them can drive compassionate regulation and equality, diversity and inclusion in healthcare. So thank you very much for your time.
Thank you so much, Tista.
Me.
We have several questions that have come through as you've gone through the presentation today. Just going to bring them up. 1 second.
Okay, so this question from Dell. What's your centre doing to reform that is more punitive than corrective for doctors' errors? Right, okay, yes, and the vote of no confidence by the BMA. Well, hopefully I've talked about that. So one of the big challenges that we've got is the Medical Act from 1983. And there are requirements in that Medical Act and following it, as we have to, because that's the current law, that means that things are a lot more adversarial than we would like. And that is why all of these initiatives that I've talked about, they're almost a workaround to try and provide that support, because the law as it stands is punitive, or the impact of it is punitive. So that's a part of it. And as I say, there are initiatives like doctor support services that we have in place because we know exactly that. The other thing that I would say is we've been lobbying for this change, as I said, since 2013, and we're just one voice. And what really makes a difference is when other colleagues, other partners in the system also lobby for that change. So one of the challenges that was made at the BMA annual representatives meeting, and a challenge that has been made a number of times from partner organisations, is that why do you still have your right of appeal? Okay. Now, we said years ago that we're very relaxed about that right of appeal going. In fact, our chair, Carrie McEwen, was on the review committee, the Williamson review, that recommended that. So we're really relaxed about losing that right to appeal, okay? But it's not within our circle of control until that legislation goes through to take away our right of appeal. We are still required to appeal. cases. So that's a slightly convoluted answer, but hopefully demonstrates that there's a lot that we want to change, and we're working with partners to try and drive forward those changes, but they're not within our circle of control. Okay, so really visible actions on ED&I are needed. Yes, they are. There's a document, unfortunately, my animations weren't working on the slide. So one of the documents that was covered up actually by the IMG induction document is it's called the MRES. That's a medical workforce rate equality standard. The MRES first 5. So we worked with, some of you may be aware of Anton and Manuel, Partha Carr. We worked with Anton and Partha, the then leads of MRES, on this first 5 action plan. And those speak to those visible actions. You might also be interested in the NHS's recently released ED&I improvement plan. And again, we're really pleased that that includes things like the induction, but also more around representation, etc. So this needs to be shouted out loud and clear. But the first 5 report released earlier this year, that talks through a number of those visible actions that partners need to take, including us, to demonstrate that it is the walk and not just the talk. And please do have a look at our action plan as well that I shared on screen earlier. So, because again, you'll see that there are actions, not just rhetoric. Okay, civility. So I'm just checking that I understand this question. So the discrimination of colleagues is apparent even from the pre-registration process. So is that the, so we're talking about medical school. I think we might be talking about medical school or international, it won't be international graduates because there is no pre-registration process there. So with again, we work with medical schools, and this organisation, in fact, has contributed to work on decolonising the medical school curriculum. So again, we are working with them to drive change in at undergraduate level. And we can see, again, the report that I shared with you shows some of the difference that that is making. And we'll continue to do that, working with the partners to ensure that the discrimination that is there at undergrad level, that is there at postgrad level, changes. We have a question here on the induction. So if you register with the GMC and do the Welcome to UK practice course that we deliver, then yes, that can be transferred. You can, you get certificates as well for that. So yes, absolutely. Okay, question here. Oh, thank you, which is lovely. Yeah. How do we encourage a healthcare worker to respond to discrimination? Yeah. So we encourage healthcare workers to raise it. First of all, freedom to speak up is a great route, but it needs to be raised at that employer level, because it's the employer who needs to look at the trends and see if they need to do more work as an organisation to prevent their healthcare workers, their colleagues, from coming to harm. Now, I understand that it can be really difficult. It can be, it puts you in a vulnerable position anyway, and then having to raise it, having been subjected to it, is, an additional vulnerability. So there are routes, and we've got a Speaking Up hub that gives you advice and signposting around how to raise things. And then going back to what I was saying earlier, a really important part of all of this is allyship. So as I said, things like unconscious bias training, doesn't work so much, but allyship does. So yes, we encourage individuals to raise things. We've got support on our Speaking Up Hub to do that. Organisations have Freedom to Speak Up Guardians. So there are loads of resources there for the individual. But I think in order to change cultures, we need much more around allyship as well. Okay, public involvement, patient engagement. Yep. Yes, we are. So we have a public involvement and patient engagement group. So there is that group. I personally am not involved with that work, but whenever we have things like consultations, I talked about the good medical practice consultation, we work extensively with patient and public organisations as well. And my team will go out and do some of that. So yes, there's plenty of that work at the GMC too.